بسم الله الرحمن الرحيم. اليوم راح نبدأ بالمحاضرة الثانية للdiarrhea, diarrheal disease in children. As you remember, we divide the diarrheal disease in children into three clinical types: acute watery diarrhea, chronic watery diarrhea, and bloody diarrhea. The most common type is the acute watery diarrhea. This is in children under 5 years. It accounts for about 75% of all episodes of the diarrhea and 50% of all death from diarrhea. So it is the most common type of the. What is the etiology? It could be due to the viruses, which is the most common. Actually, viruses account for more than 70% of all cases of the acute watery diarrhea. And the most important virus is the rotavirus, or it could be caused by the bacteria. These are the examples of the bacteria, or protozoa, the most common protozoa, the Cryptosporidium. WHO said that this Cryptosporidium is one of the most common cause for the acute diarrhea in developing country. Pathophysiology, it is usually a secretory or non-inflammatory invasive. And the clinical effect of acute water diarrhea is due to the loss of water in the stool, electrolyte in the stool, water and electrolyte in vomit, and water due to febrile sweating. The net result will be the loss of the fluid and electrolyte with or without dehydration. Clinically, it is generally not possible to identify whether the acute water diarrhea caused by virus or bacteria or protozoa from just a clinical feature. But there are certain points we can differentiate between the acute watery viral diarrhea and acute watery bacterial diarrhea. Actually, this is أعتقد إحنا حكينا عليها بالمحاضرة الأولى. What is the point to differentiate between the acute viral and acute bacterial diarrhea. And the diagnosis of the laboratory diagnosis, I mean, it is not necessarily for either the diagnosis or for the treatment. It is used actually for the epidemiological surveillance and determination of antibiotic sensitivity. And it is often depend on highly sophisticated technique and equipment. For example, rotavirus need identification of the virus via the stool, in the stool by the immunoassay. Enterotoxogenic E. coli need culture specific media. E. coli, Vibrio cholera also need culture, stool culture or rectal swab or TCPS, thiosulfate, citrate, pulsol, sucrose, agar, and also the dark field microscopy to see the coma or rod with characteristic mortality. In the treatment, there are key steps including the prevention of the dehydration. There is no sign of the dehydration. Treatment of the dehydration present. Treatment according to the severity of the dehydration, whether mild, moderate, or severe. And breastfeeding should continue throughout the episodes of the diarrhea and restart the solid food after 46 hours of the oral rehydration. And extra meal should be given for at least 2 weeks. And antibiotic should be used for specific indication. This antibiotic occurrer should not be used routinely in the diarrhea because the majority of the cases are due to the viral infection. For example, in patients with cholera, suspected cholera, we can give the trimethoprim or erythromycin as alternative if the patient has sensitive to the sulfa drug. We should not give anti-diarrhea drug, especially loperamide, especially below the age of 3 years. Now we come for the acute diarrhea. Acute blood diarrhea, الحقيقة, it is the second most common type. It is usually less than 14 days, associated with passing of the blood. It is account for about 10% in those under the age of the 5 years. with 15% of the death due to the etiology. Could be due to the Shigella or Campylobacter or non-typhoidal Salmonella enteroinvasive Entamoeba histolytica. The most common is the Shigella. The most common is Shigella. This is account for about more than 50% of all the cases of the diarrhea, bloody diarrhea in children under the age of 5, and it's account for about 80% of all death from bloody diarrhea. Campylobacter with Shigella are the most common important pathogen below the age of 2 years. The other special Entamoeba histolytica بالحقيقة rare. It is account for about 2% only of all cases of the dysentery in children. Generally, it is inflammatory invasive etiology, but some of the bacteria might lead to produce acute water diarrhea by a secretory mechanism. Example is the Shigella and Campylobacter jejuni. It leads to extensive damage to the bowel by mucosal inflammation, erosion, formation of microabscesses, and the production of the exudative containing blood and mucus. And that is why in the general stool we search for the blood and the mucus in patients with dysentery. These findings is typical of Shigella, Campylobacter, non-typhoidal Salmonella, and enteroinvasive E. coli. Toxins can be produced by certain bacteria, produced by invasive bacteria, which contribute to the diarrhea. There are two types of the toxins, either cytotoxins or enterotoxins. Cytotoxins are the toxins that kill the cells, including the enterocyte and colonocyte, causing blood diarrhea. And enterotoxin, this will lead to the water diarrhea by disturbing the electrolyte flux through the cell membrane. And these toxins also are responsible for one of the important complications of the acute blood diarrhea, especially in shigellosis and hemorrhagic E. coli, because of the producing of the Shiga toxin and Shiga-like toxin. This complication called hemorrhagic urine syndrome, where the patient become irritable, have microangiopathic anemia, hemolytic anemia, is present with pallor, with thrombocytopenia, and features of the acute renal failure. This is one of the important complications, and this very dangerous complication require urgent treatment, and the cornerstone of treatment is by dialysis. Okay. Clinical feature of shigellosis, as I say, this is the most common types. More than 50% of all cases of blood diarrhea caused by the shigellosis. Shigellosis is a cause of blood diarrhea, but usually the condition started as watery diarrhea for 1 to 2 days, and the incubation period 1 to 5 days. It is usually lasts 2 to 10 days when it is not fatal. It can cause frequent stool. Stool بحقيقة they describe that the patient spend most of the time in the toilet. It is from 30 to 100 times per day. It is small, frequent, associated with tenesmus, fever, rectal pain, abdominal cramp, anorexia, dehydration, and febrile convulsion. Intestinal and extraintestinal complication is also possible. Example of these intestinal complication هي طبعا الweight loss and falling of nutritional status because of the anorexia, increased catabolism, and protein losing enteropathy, rectal prolapse because of the tenesmus and the straining, intestinal perforation, toxic megacolon, while the extraintestinal include bacteremia, hyponatremia, hypoglycemia, hemolytic urine syndrome, secondary infection like pneumonia, etc. So, which patient with shigellosis is at more risk for these complications? Patient during the first year of life with severe malnutrition who had measles in the past 6 weeks. These 3 categories rendering the patient more liable for the intestinal and extraintestinal complication. Other pathogens, the manifestation بالحقيقة is milder and the complication is rare. For example, Entamoeba histolytica it usually have insidious onset over 2 to 3 weeks. And usually the patient, despite of the bloody diarrhea, he is well looking, he is febrile, he has some mild abdominal pain. While in shigellosis, the patient is toxic looking, he looks like moribund محتضر يعني. You feel that the patient is about to die. In the laboratory diagnosis, we can send for general store examine looking for the basal RBC, intermediate trophozoite that contain the RBCs. When the general stool can contain blood RBCs, I mean more than the basal, this is in favor of amoebiasis, sorry. And when it is contained basal more than the RBC, this is in favor of the shigellosis. Also, we can send for the cultural specific. About the management include the key steps. Refer the patient at high risk for day. We say about the high risk. High risk, I mean high risk for the complication, whether intestinal or extestinal. Those below the age of 12 years with measles in the past, severe malnutrition, severe dehydration, etc. Treat dehydration usually by the ORT. Dehydration الحقيقة هي rare, لكن when present it is indicates severity of the condition. That is why I put it here with severe dehydration as a risk factor for the complication and risk to hospitalization. Oral antibiotics should be given over 5 days for shigellosis. These include ampicillin, methadone, nalidixic acid, ceftriaxone, and fluoroquinolone. Fluoroquinolone بالحقيقة is contraindicated below the age of they say 17, some say 12, because of the risk for the erythropathies. So we try not to use it in the young children. Frequent feeding, including continuous breastfeeding, and follow up the patient after 2 days. We'll see if there is any improvement by the decrease in the number of the stools, subsidence of the fever, the patient become good, feeling better, abdominal pain is better, and the appetite is better. If there is improvement, we continue for 5 days. If there is no improvement, we shift to the other antibiotic, second line antibiotic. For example, if we use the ampicillin for 48, I think this is wrong, 48 hours, not days, 48 hours, 2 days. So ampicillin. If we use the ampicillin, second line methadone. If we use methadone, we can use ampicillin, etc. And we wait for another 2 days. If the child not improved, we have to refer the patient to the hospital, or we treat for the amoebiasis. So after 2 drugs, after 96 days, 6 hours, sorry, 4 days, if there is no response, we can refer the patient to the hospital, or we can treat the patient for amoebiasis. Surely we need not to give any anti-diarrhea drug like that. What is the indication of the antiparasitic? This is detection of the intermediate trophozoite containing RBC in a fresh stool sample, or clinical failure of 2 different antibiotics against Shigella. Just we talk about it. Drug of choice is metronidazole 10 mg per kg 3 times a day for 5 days. Nutrition and dysentery is very important. It is one of the contributor to the poor, a major contributor to, dysentery, a major contributor to poor nutritional status. And poor nutritional status is a contributor to the risk for the complication from dysentery. So, to prevent the development of malnutrition and promote repair of the bowel, good feeding practice is needed during the diarrheal episodes. Breastfeeding should continue, and older children should be given food after 40 hours of the oral rehydration, and extra daily meal should be given for at least 2 weeks after the treatment. You can see the same 3 points in the blood diarrhea. in the as in the water diarrhea. Now we come for the persistent diarrhea. Persistent diarrhea, this is indicate watery or bloody diarrhea usually started acutely and lasts more than 14 days. In majority of the cases بالحقيقة start acutely apart from some cases of the giardiasis or uveitis who might have insidious onset. It is a major cause of the malnutrition, and the malnutrition is one of the major contributors to the persistence of the diarrhea. So there is a vicious circle. Persistent diarrhea lead to the reduced intake and malabsorption of the nutrient, leading to the malnutrition, lead to the impaired defense mechanism, leading to the persistent diarrhea. We return to the beginning. So it is a vicious circle. Persistent diarrhea worsens the nutrition status through. So why the persistent diarrhea lead to the malnutrition? By reduced dietary intake because of the anorexia and incorrect eating during the diarrheal episodes, poor absorption and digestion of the nutrient due to the damaged small. In the persistent diarrhea, it is an important source of the worldwide morbidity and mortality in infant children. It is very important cause for the morbidity and mortality. It is one of the difficult cause for the diarrhea to be treated. It is account for about 2.2 million childhood deaths worldwide. It is responsible for 2.2 million childhood deaths, and death is usually associated with malnutrition. During the episodes of the diarrhea, persistent diarrhea, if the patient has pre-existing severe malnutrition, I mean marasmus or kwashiorkor, he or she is at 20 to 60 times more likely to die than those who are well nourished. So it is better to have persistent diarrhea in a well-nourished child than the malnourished because the mortality is very high. Death is usually associated with non-intestinal infection. Those patients with persistent diarrhea with malnutrition have immune suppression, so they are more liable for pneumonia. Another cause for the death is the dehydration. بالحقيقة dehydration in persistent diarrhea is rare, but when it is present, it is an ominous sign and needs to be treated carefully in the hospital. Epidemiology: persistent diarrhea accounts for about 11% of all episodes of diarrhea and 35% of all death from there. ده شوفوا الرقم هنا عالي. 35% death. 3 to 10% of acute diarrhea become persistent, and if the pathogen that cause acute diarrhea generally separate by fecal-oral transmission through contaminated food, drinking water, or direct person-to-person separate. Risk factor: which patient with acute diarrhea become persistent, which patient with bloody diarrhea become persistent. So pre-existing moderate or severe malnutrition اللي دائما نركز عليها ونحكي عليها. Malnutrition is very important factors in persistent diarrhea. Ages than 6 months. The peak is 3 to 6 months. Also impaired immunity, especially the current measles during the last 6 weeks. Also malnutrition, micronutrient deficiency, especially vitamin A and zinc, and if there is concurrent infection, pneumonia and HIV in certain areas. Sign of vitamin A deficiency is also a risk factor for persistent diarrhea. History of diarrhea in the previous 2 months, which means that the patient with recurrent diarrhea is more likely to persist than the patient with the usual episodes of the diarrhea per year. Failure to breastfeed also, exclusive breastfeed is also an important factor. Acute diarrhea is more likely to persist if there is visible blood. Also, if there is visible blood in the mucus, هاي بالنسبة للأكيوت diarrhea, visible blood or mucus in the soil, which means that the patient with acute blood diarrhea is more likely to persist than the acute watery diarrhea. Severe diarrhea manifests by high stool frequency, 6 or more days, more time per day. Severe dehydration, consumption of the cow's milk during the episodes. Patient on the cow's milk, patient on the formula is more likely to persist than the patient on exclusive breastfeeding. On the other hand, less likely to become persistent if there is effective antibiotic treatment against shigellosis, for example, exclusive breastfeeding and continue feeding during the diarrhea in older children. هنا أنا أركز على continued feeding during the diarrhea because some doctor says that there is a need to stop the feeding during the acute episode of diarrhea in order to resting the bowel. This is not correct. We have to start nutrition early, feeding early. This will lead to the short duration, rapid healing of the acute watery diarrhea, and less risk for the persistent. Etiology: the persistence of an enteric infection by one pathogen, the persistence of enteric, which means that the patient in the diarrhea, for example, by giardia or rotavirus, and it is persistent forever. Failure to elimination of the pathogen, this pathogen could be due to the impaired host immunity or resistance of the pathogen to the antimicrobial agent. This is an uncommon cause. Yeah, uncommon to have one pathogen. The usual feature is enteric infection caused by a different pathogen. At different stage of the persistent diarrhea, we can discover different pathogens. Some cases of the persistence due to the non-infectious causes. The classical example who are lactose intolerance following the acute diarrhea. We can't find any microorganism, but the patient still have diarrhea because of the secondary lactase deficiency. Also, cow's milk protein allergy, sensitive to the antigen, cow's milk protein allergy, soya allergy أيضا. So this is not associated with any microorganism can be detected in the intestine. The pathogens which have been proposed as an important cause for persistent diarrhea are enteroaggregative, E. coli, Cryptosporidium, Giardia, Lamblia, Shigella, and in 30 to 50% no pathogen isolated. The common cause of the acute diarrhea, which is the rotavirus, is rarely implicated as a cause for persistent diarrhea. Histologically, we find thin mucosa, subtotal villus atrophy, crevat hyperplasia, blunt microvilla. These changes can persist well after enteric pathogen can no longer be isolated from this stool. Clinically, we have to assess the degree of the dehydration. Dehydration is very important. It is one of the risk factors for the death in the persistent diarrhea. It is a very dangerous sign. Any degree of the dehydration should be treated in the hospital. Sometimes the malnutrition make the assessment of the hydration state is difficult. For example, we cannot depend on the skin turgor, but still we can use some sign to assess the dehydration, like the dry mouth, tongue, and eager to drink. These are signs of some dehydration. Very dry mouth and tongue, cool, moist extremities, and weak or absent pulses, radial pulse, sign of severe dehydration. Sign of septic shock might be mistaken for signs of the severe dehydration. Sometimes the patient present, he is malnourished, and malnourished, as you know, they are more liable for the infection, and the separate of the infection, they are more liable for the septicemia. So how we can differentiate between the patient with septic shock and severe dehydration and persistent diarrhea? There is no history of diarrhea in such patients. We have to establish by the history طبعا whether the diarrhea is watery or bloody, and we have to also ask about the onset, whether it is acute or insidious. In majority of the acute. We have to assess the sign of malnutrition. We have to search for the signs of the kwashiorkor, merasmic kwashiorkor, for sign of the trace element deficiencies, zinc, vitamin A, iron, etc. And we have to assess the weight for age, weight for height, and mid-upper arm circumference in children age 1 to 5 years. Surely these should be checked after the assessment of rehydration and correction if present of dehydration. هذا الجدول يوضح لنا malnutrition whether it is moderate or severe, how we can diagnose malnutrition according to the weight for age, weight for height, mid upper arm circumference. أعتقد واضح ما يحتاج لشرح. Also in the history we have to determine any concurrent illness and immunization history. Laboratory we have to send for general stool with stool culture, immunological for the diagnosis of the antibody or antigen antibody in the blood, antigen in the stool, and stool chemistry for stool pH. Stool pH normally 5.5 to 6.5. If it is less than 5.5, this is acidic, and this indicates that the patient has lactose intolerance. Also, not only the pH, but the presence of the reducing substance indicate that the patient has carbohydrate malabsorption as a secondary for the diarrhea. In the treatment, we have key steps. First, we have to prevent or treat dehydration. Dehydration is very important. Relation of dehydration person is very important because it has ominous sign. Any degree of the dehydration should be treated carefully, and the patient should be admitted to hospital as possible. Should be treated with oral rehydration solution. We should avoid IV fluid as possible because IV fluid carry a risk for the hypervolemia and secondary heart failure. Even the dextrolite, ORS, should be of a special type that contains less sodium and more potassium. This type of ORS or oral rehydration solution called Rizomyl. Rizomyl means it is an abbreviation of rehydration solution for malabsorption. So, IV fluid only indicated if the patient has hypovolemic shock. Oral antibiotic, بالحقيقة the cornerstone of the treatment of persistent diarrhea is the nutrition. It is not antibiotic like the bloody diarrhea, ولا هي IV fluid like the acute watery diarrhea. So antibiotics should not be given routinely, but there is certain indication. Patient with a bloody diarrhea, patient with specific microorganism diagnosed by the stool microscope examination or culture, for example, giardiasis or anti-investigative, and also those patients with severe malnutrition. بالحقيقة حتى البيشنت in severe malnutrition should give routine antibiotic إذا كان عنده persistent diarrhea for 5 days. Ampicillin and gentamicin is one combination. راح أعيد الأورال antibiotic. الأورال antibiotic بالحقيقة should not be used routinely because the cornerstone of the treatment in patients with persistent diarrhea is the nutritional management. But there is still indication إذا كان البيشنت عنده bloody diarrhea and the microorganism diagnosed in the stool, general stool or culture, for example, giardiasis or amibiasis, or the patient has severe malnutrition. Those patients need antibiotic, which is oral antibiotic, for 5 days in the hospital. One of the combination is gentamicin and ampicillin. Nutritious diet is very important. ومثل ما قلنا احنا هو cornerstone of the treatment is the nutrition. Should provide at least 110 kilocalorie per kg daily and should not worsen the diarrhea, which means we should not give an item that is make the diarrhea worse through, for example, lactose intolerance. ما ننطي مثلا lactose formula اللي patient because of the persistent diarrhea. احنا قلنا persistent diarrhea more than 2 weeks تمام. More than 2 weeks there is damage of the intestinal brush border, there is damage of the cell that produce the lactase enzyme, so they are more liable for secondary lactase deficiency. So we have to give lactose-free formula. More children can be fed at home using locally available food without IV nutrition. We can encourage breast milk, yogurt instead of animal formula feed, the strict amount of animal milk, or if yogurt is not available. In older children, milk as described above and easily digested and nutritious food can be given also. Solid diet for home feeding should be culturally acceptable, readily available, high in energy content, provide adequate essential and micronutrient, be well cooked, be mashed or ground, easier for small children to swallow, contain added vegetable to increase the calories. Non-breast milk should be given undiluted and mixed with cereals. بالحقيقة من سوى mixing للملك واللي هو non-breast with the cereal, this is improve the absorption of the lactose by the intestine and reduce the risk of lactose intolerance. Food should be given a small amount every 3 to 4 hours, at least 6 times per day. I think this is the last slide in the treatment. Micronutrient supplementation. All children, whether treated in the home or in the hospital, should receive twice the daily allowance, recommended daily allowance. The recommended daily allowance vitamin A 400 microgram, folic acid, zinc, iron, copper, and other. Zinc supplementation produce marginal reduction in the stool frequency and will improve the mucosal function in some children. Actually, it is they found that is important for the healing of the intestinal mucosa. Thank you.